Hello everyone, welcome to our presentation. Today we're going to talk about 5 critical areas in healthcare technology. First, computerized physician order entry by diagnosis. Second, electronic health record system. Third, barcoded medication administration. Fourth, telemedicine. Under this, we're also going to touch on Chronic Care Act. And last but not the least, future, focused on personal consumer health information technology. So, sit back, relax, and enjoy our presentation.
Hi, I have a new order for your patient in room 403. I need this stat.
Okay. Can't. Okay, so it's for the right patients. C-stat. Don't know the medication. I think kind of looks like acetaminophen 500. I don't have the time to figure this out, so I think it's acetaminophen 500. I'm just gonna go for it, and yeah, this is too much time. I can't read this writing. Okay.
Hi, I put in a new order for your patient in 403. It's on the EMR.
Okay, thank you. Okay, I see new order, stat, acetaminophen 500, my mouth. Great. I'm gonna acknowledge that order. That's so nice that there's a properly written order, so easy to read. I'm gonna know I'm giving my patient the right meds. Computer Physician Order Entry. CPOE is a health information technology implemented with goals to benefit many stakeholders. Goals include improving medication safety, quality of care, and reducing costs. So what is computerized physician order entry? It's an application that is often associated and seen with electronic health records. It allows physicians and providers to enter treatment, instructions, interventions, and medications into the EHR. There are 3 distinctive features of CPOE. 1. Physicians enter the order themselves instead of a secretary or another assistant. 2. The physician works through a digital interface, meaning they place orders and can discontinue orders on the computer instead of having to handwrite prescriptions and fax orders. This helps to take away one of the larger complaints that come with handwritten documents, the ability for people to correctly read the writing. The third important feature is that there is structure and standardization with entering orders. There are clear order sets available and established for entering common orders. Another obvious ability of some advanced EHR systems is that it can integrate patient information into the ordering process. This allows the computer system to access what the physician is entering against the chart. This is helpful in looking at allergies, labs, medication, contraindications, in some cases even renal and weight-based dosing. Since we are looking at how health IT is growing and expanding in our nation, I thought it would be important to look at how CPOE and other health IT subjects like barcode scanning and the use of EHR have been funded and implemented so far. As you can see, there have been several things set in place to grow health technology and especially CPOE in the last decade. Between 2004 and 2005, the Agency for Healthcare Research and Quality awarded $168 million in funding for health IT. This agency is a U.S. government agency that functions with the Department of Health and Human Services. So within this, the grants and contracts were created with the intent that the technology was implemented to impact the quality, safety, and efficiency of healthcare delivery. In 2009, the HITECH Act was approved as part of the American Recovery and Reinvestment Act in order to stimulate and encourage the adoption of electronic health records and further support technology in the U.S. This act stipulated that in 2011, a financial incentive would be employed if the healthcare providers demonstrating meaningful use. Another Health and Human Service Department, Center for Medicare and Medicaid Service, began the incentive program for using EHR technology. It is CMS that created the required 3 stages necessary for receiving the financial incentive. 1. They had to show basic EHR adoption and data gathering, or even using a CPOE system. The second meaningful use stage added onto stage 1. Now they also have to show the ability to coordinate care and share clinical information electronically. The third stage is to improve healthcare outcomes, and this is a stage that is a little less clear as to what defines meeting this stage. I do want to add that CPOE usage increased after the HITECH Act passed, and that positive early evidence was the argument for federal funding in the beginning. Because of this early evidence, CPOE was promoted by political leaders and large consumer groups, such as Leapfrog. So a lot of emphasis is placed on the relationship between CPOE and medication errors, since one of the goals of CPOE is improving medication safety. It has been shown that 90% of medication errors occur as a result of ordering or transcribing orders. Another system that is implemented within the EHR to aid the CPOE is the Clinical Decision Support System. This is a specific application that assists physicians while entering orders. It works at the dispensing stage, meaning it has default and normal values for drugs, route of administration, and frequency. This helps physicians order a medication safely. It also has clear safety features, such as checking for drug and drug interactions and allergies to the patient. Another feature of the Clinical Decision Support System is the order sets it has built into the system. So because computerized entry allows physicians to not have to type out full, complete orders, and it has this key available for them, safety of the patients is often assessed with the use of CPOE. In the clinical practice and use of CPOE, some would argue that having all the aid from the CDSS could lead to errors in ordering. While to support safety, there are still several safety checks implemented in the CPOE process. One does not simply put the order in, let's say for a new med, and that med is just given. Other members of the healthcare team, like the nurses, have to still review and accept that order in the system. So this then allows the nurse or other members of the healthcare team to work towards reducing errors by paying attention to med changes. A second safety measure that is implemented is the use of barcode administration. And you can see in 2013, the meta-analysis found that the likelihood of a prescribing error was reduced 48% when compared to paper ordering, resulting in 17 million med errors prevented a year in the US. And you can see in 2013, the meta-analysis found that the likelihood of a prescribing error was reduced 48% when compared to paper ordering, resulting in 17 million med errors prevented a year in the US. I have talked a lot about the safety and benefits that patients receive from using CPOE, like reduction in med errors, but the utilization of CPOE also affects the daily workflow for the healthcare team, which means it also affects other stakeholders, such as the nurses and physicians. An example would be the Evergreen Health experience in Seattle, Washington, where they found the benefit when using EHR and CPOE. Overall, CPOE is a health IT implemented through policy and financial incentive to improve safety measures for both the patient and healthcare team, while also working to lower medication error rates. Let me call the clinic.
2,000 years later, 6.5 hours later, a few inches later.
Yes, hi, finally. I've been trying to contact your office 3 times now, and it always goes to voicemail. I don't know why. I just moved to Portland from Houston, and I need to get my first comprehensive checkup and find a new provider. Yeah, tomorrow at 5? I'll take it. Thanks.
Hi, how are you? What brings you here?
I'm doing okay. I just need a comprehensive checkup, and I need to get a new provider.
Okay, well since you're new here, we have to call your previous primary provider and ask for your information to be faxed or sent to us. I'll give them a call, and while you're waiting, you can just fill out this new patient booklet, including listed medications and family history and other important health concerns.
I guess I need to call to make an appointment. Oh wait, I can just do it online.
Hi, how are you? What brings you here?
Hi, I need a comprehensive checkup and I need to find a new provider.
Oh, okay, awesome. Well, since you're new here, let me look you up in our new patient transfer request list. Oh, there you are. I see here that your primary provider submitted a request for you to be moved here. If you can just look over here and make sure everything's up to date.
Yes, everything looks good.
All right then, well, welcome to our clinic. Since we've now accepted your transfer and have access to your health record, I'll let the doctor know and she'll be right in with you. Okay?
Thank you.
The scenes before this slide show the before, when EHR didn't existed yet, and the after, where medical professionals are utilizing it at present. So what is EHR, or electronic health record? And what do we usually see in it that makes it significant? So EHR is a digital version of a patient's paper chart. EHRs are real-time, patient-centered records that make information available instantly and securely to authorized users. EHRs can include medical history, diagnosis, medications, treatment plans, immunization dates, allergies, radiology images, lab and test results, and evidence-based tools used by providers for the patient. Here are just some images showing what an EHR may look like. Surprisingly, EHRs are not brand new. The first EHRs appeared in the 1960s. Mayo Clinic in Rochester, Minnesota was one of the first major systems to adopt an EHR. EHR implementation, though, nearly doubled from 2007 to 2012, growing from 34.8% to more than 71%. In 2011, the Centers for Medicare and Medicaid Services, or CMS, established the Medicare and Medicaid Electronic Health Record Incentive Programs. These programs are utilized to encourage eligible professionals, eligible hospitals, and critical access hospitals to adopt, implement, upgrade, and demonstrate meaningful use of certified EHR technology. This slide shows the benefits of EHR. First, time savings, which means that no more waiting for patients' paper records to be faxed or scanned. Second, increased care coordination. Patient data is legible, clear, and accessible to all authorized providers. Third, reduced risk. Miscommunications that could lead to malpractice lawsuits are curbed. Fourth, more efficiency. Patients wouldn't fill out medical history paperwork more than once. Fifth, less unnecessary tests. Redundant testing and inapplicable procedures are better avoided. Last but not the least, better research. Data for public health monitoring and reporting is more available. Adding to all of this, it does make transfer of care or new patient processes much more efficient and coordinated. Since we talked about the benefits and the good of having an EHR, we are now going to touch on some of the disadvantages. And here are some. Privacy and security of protected health information, or PHI, interoperability of EHR systems, startup costs pertaining to software, training, downtime, and etc., choosing an EHR system, the learning curve, and last, inequalities in computer literacy amongst the users.
Hi, Erin. Can you confirm your name and date of birth for me?
Erin Scott, 101380.
Awesome. I'm just going to scan you real quick and make sure that this is the right med for you right now. Perfect. We're all set to go.
Sounds good.
So barcoded medication administration was created by a nurse in Kansas in 1944. She was inspired by the way rental car companies use barcodes to track and monitor rental cars and thought that this system could be applied to nursing care as well. In a total of 10 years, this went from an initial inspiration and idea to being federally rolled out to hospitals and medical facilities throughout the country in 2004. As we talked about before, 19% of adverse effects in healthcare settings are related to medication errors at one of the 3 stages in medication administration and handling. These stages are ordering, dispensing, and administration/reconciliation. Given the first two interventions we discussed, computerized order entry and electronic charting, these are the first two interventions using information technology for the first two stages of medication administration and handling. The first stage of medication administration begins with the physician's order, which is entered electronically into an electronic health record chart like Epic. This order is then filled and dispensed by the pharmacist, and the medications are stocked into an automated dispensing machine like a Pyxis, which is another intervention in itself to prevent med error. When it's finally time to administer the medication, the nurse then logs into Pyxis and pulls the meds for the patient. Once we're in the patient's room, the third stage and final intervention comes into play, barcoded med administration. The nurse logs into Epic. They then scan the patient's barcoded ID band, which confirms that we have the right patient. Then the nurse scans the barcodes on the meds, and the electronic chart system will check, reconcile, and document the meds in real time. This ensures that we have 5 of the 6 rights of medications being checked before we actually give the med to the patient. When we're sure that we have the right drug for the right patient, using the right route with the right dose and at the right time, we're able to safely give the med to the patient, ensuring potential med errors have been avoided. In just a year after this technology has been in play, a study by the New England Journal of Medicine in 2005 has shown that this lowered the rates of medication error by 41%.
Hi.
Hi.
You must be Rayleigh?
Yes.
All right, I'm Kevin. Nice to meet you. I'll be your nurse
you.
today.
Great.
If you just want to take a seat here, I'll get going on some vitals real quick.
Okay.
And then we'll have a computer set up for your visit today.
Hi. Hi.
Hi, how are you doing today?
Good. How are you, Dr. Taylor?
Good. So I reviewed your chart and everything's looking good, temperature, weight. Do you have any concerns?
Not at this moment, no.
Your port hasn't been giving you any problems?
No, it's been working well, I think. Flushing okay?
Good to hear. Okay, so I'm not concerned about anything at this point, so we can go ahead and schedule another appointment for about a month out.
Sounds great.
Alrighty, thanks for leaving me. Have a good day.
You as well.
Yeah, bye.
Our next topic is telehealth. The scene we just saw is one example of the many ways that telehealth has improved care delivery for patients. Here are some of the other benefits. It's convenient and time effective. You can deliver behavioral health services from home, the office, or while traveling. Real-time video allows for fast communications, and lack of travel saves time for both parties. It's also an opportunity for extra income, and it's low cost. Offices can offer additional or non-standard appointment hours, plus patients aren't paying for transportation to a primary clinic, and caregivers don't need to take time off. It's secure and private, which means it's a HIPAA-compliant platform. It's simple. You can use your private computer with a camera and high-speed internet. It can open access to more patients because you can treat members who live in rural areas or have mobility issues. It may also reduce no-shows and cancellations because there's no member travel time required. Additionally, it can save lives. For example, in the past, a neurologist would be on call, and if a possible stroke patient came into the emergency department, they had to wait for the doctor to get there, which could take up to half an hour, until their symptoms could be assessed and they could make the decision to administer TPA or not. With telehealth, there is a hotline to call if a possible stroke patient comes in, and their symptoms can be assessed over the phone within minutes, which allows better outcomes for patients. Telehealth has been around for a few years now, but recently it has started to expand. I'll talk about how that is in a minute, but here are some of the areas currently being focused on. In the past, it mainly was used for people living in rural areas, but now it's expanding to dialysis patients. No matter their location, they would be able to have monthly consultations either in-home or at a dialysis center, and would still meet with their nephrologist once every 3 months in person. Patients presenting with stroke symptoms in rural areas. It also allows for funding and baseline prices, not as a supplement, and legislation is working to create penalties for going over benchmarks, which encourages the use of telehealth since it can be more cost-effective than other options. For instance, a Skype call from your doctor at the dialysis center the patient normally attends rather than having to send out a home health nurse for assessment or having the patient drive all the way into the doctor's office and having to take a day off of work. One way that telehealth is funded is through the new Chronic Care Act that passed in 2017. Chronic care stands for creating high-quality results and outcomes necessary to improve chronic conditions. The Chronic Care Act specifically focuses on home-based care, managed and accountable care, telehealth and other technologies, as well as government accountability office inquiries. This applies to those persons receiving Medicare, but like I stated earlier, legislation is working towards creating penalties for going over budget, which would encourage increased use of telehealth since it's more cost-effective than other alternatives.
In the world of healthcare, health information technology has had a profound impact on the way professional medical services are delivered, tracked, and communicated. But in decades to come, personal health information technology is likely to have an even bigger impact. Although health information technology may hold the key to improving both the efficacy and efficiency of professional healthcare, the question of who pays for this technology, as well as who benefits and does not benefit from healthcare efficiency in a pay-per-service healthcare system, creates roadblocks that keep this technology from its maximum growth and implementation. In the private sector, however, business is booming, and health information technology for the consumer is developing at a rapid pace.
How long was that run? It's like 20 minutes. Our heart rate was 110 that whole time.
Awesome.
So good. Crushed it.
People from all walks of life are already using fitness apps and fitness trackers to help track their progress and motivate themselves to further healthy action. These devices access and interpret data from the body and provide personal health information, but that's just the beginning.
Hello?
Hello, Rayleigh. This is Anna from Dr. Presnell's office. I'm calling you today because we'd like to have you in for an appointment to discuss some of your health data you submitted from your Apple Watch. We received an alert that you experienced an episode of heart rate irregularity this morning. Did you notice anything different during your run?
I'm not really sure, but I have noticed that my blood sugar has been fluctuating a lot on my Apple Watch, and I've been feeling extra tired.
Why don't you come in this afternoon and we'll run a few tests to see if we can get to the bottom of it.
Okay, I can make that work.
Okay. Have a nice day.
Even 5 years ago, getting a blood sugar test and an EKG from your watch would have sounded like a science fiction movie. Late in 2017, however, the FDA cleared the first personal, wearable, clinical-grade EKG that replaces the regular Apple Watch band. When paired with the Apple Watch, the Cardia band, developed by a former CEO at Google+, gives you a real-time 30-second EKG anytime, anywhere, with unlimited storage and history, and a monthly summary to send to your doctor. Its smart rhythm technology works with the Apple Watch to monitor your heart rate and physical activity, sending you a notification to take an EKG if it senses something out of the ordinary. Apple is currently working to include EKG technology as part of the Apple Watch itself in the next few years. Continuous glucose monitoring is currently done via a small sensor just underneath the skin that measures glucose levels, which can be sent wirelessly via a transmitter to a smart device. Dexcom currently works with the Apple Watch to provide real-time glucose monitoring and reporting to diabetes patients and their physicians, with customizable alerts to warn the wearer of approaching glucose highs and lows. A bloodless glucose test via Apple Watch, although not yet available, is receiving millions of dollars in research funding via Apple each year. Tech companies like Google and Apple are also spending millions of dollars on research and development to allow consumers to create electronic personal health records of many kinds that can be tethered to electronic health records at the physician's network. Late last year, the first smart pill was approved for use in the United States, a pill with an ingestible sensor that is activated by stomach acid to detect when the pill is taken. The data is transmitted to a wearable patch, which can then transmit the data to an app on a smartphone. From there, with the patient's consent, the information can be accessed by the patient's doctor or caregivers. As of now, the Smart Pill is only available as Abilify My Sight, a medication treating schizophrenia, bipolar mania, and depression, but it is only a matter of time until the tech is available for other medications. All of these technologies, in addition to increasing the quality and efficiency of healthcare, also serve to improve the number one factor causing poor healthcare outcomes: patient adherence to medication regimens or healthy behaviors. These advances not only contribute to individual health, they also create a wealth of data that researchers can use to create further technological advances. In 2017, Apple launched the Apple Heart Study app, which can gather irregular heart rhythm data from the Apple Watch's existing sensor and send notifications to users who may be experiencing atrial fibrillation. Late in 2017, Apple announced a partnership with Stanford University to use this data to further heart science research, because Fitbit, Garmin, Jawbone, Nike, and other fitness tracking devices provide research-grade accuracy in terms of measuring steps. They are suitable for use in human physiology and pathophysiology research. As these biosensors continue to be developed, they will continue to have the potential to provide more and more solid research data.
Personal consumer health information devices will only be useful to these larger research goals to the extent that people use them consistently. In an article exploring the use of smartphone technology in apps and health promotion efforts, Cynthia Kratzky observed that the average personal health technology consumer is looking for information that will allow them to take immediate action, not in-depth research that takes a lot of time on the internet to conduct. The devices we've discussed here certainly meet that criteria, but there are other factors to consider. Researchers have derived many theories about health technology acceptance in general, and created models that help us understand the journey a new technology can take from creation to implementation and acceptance. The particulars of the theories vary, but they include factors such as perceived usefulness, perceived ease of use, performance expectancy, effort expectancy, social influence, and facilitating conditions, and in the case of online shopping and banking, trust. When discussing the acceptance of health technology in particular, researchers often refer to the health belief model, the idea that belief in a personal threat combined with belief in the effectiveness of the proposed behavior predicts the likelihood of engaging in the behavior. Researchers agree, however, that although using wearable health technology increases awareness of physical activity and/or body function and leads to a greater degree of comfort with wearable technology in general, the technology is most effective when paired with peer support and doctor monitoring. This sharing of information with others, either by choice or automatically, brings up another perspective in personal consumer healthcare information technology. Researchers doing an empirical study of the acceptance of wearable technology for healthcare purposes identified this as the privacy perspective. This perspective considers the influence of desire for privacy around healthcare behaviors or data and how it affects the decision to share personal health information with others. The potential misuse of personal health data raises privacy concerns, and researchers call the risk-benefit analysis associated with these concerns the privacy calculus. This analysis is highly personal and varies by individual, but researchers agree that the potential benefits of the technology must outweigh the potential privacy risks for the technology to be adopted. Even more than technology or development issues, this has the potential to be the critical factor in the widespread acceptance and use of personal consumer health technology.
Thanks for watching our presentation! Bye!
There we go.
Nailed it.
Nailed it.
Crushed it.
Crushed it!
Crushed it!
Crushed it!